I call upon Dr. Savya Soman to present FP227, comparative analysis of two different posterior chamber phakic lenses for correction of myopia.
Good morning. I'll be talking about a comparative analysis of two different posterior chamber phakic lenses for the correction of myopia. So, no financial interest. So, phakic lenses implantation is a procedure of choice when it comes to the correction of high refractive errors. And the advantages being it can correct high refractive error, it preserves accommodation, has a faster visual recovery, and it is a reversible process. So, the aim of the study was to compare the implantable columnar lens by the Star Surgicals in Switzerland and the implantable phakic contact lenses by the Care group in India. And the inclusion, it is a retrospective case series, and inclusion criteria included all eyes in whom the phakic lenses were implanted during the study period with a minimum of 1 year follow-up. And the exclusion criteria was any previous ocular surgeries, hypermetropia, unstable refraction, and less than 1 year of follow-up. And the data were collected from the EMR preoperatively and then at 1 month, 6 months, and at 1 year and the last visit. And the uncorrected visual and corrected visual acuities, subjective and objective refraction, the slit lamp evaluation, the intraocular pressure, endothelial density was calculated in each visit. And additionally, horizontal white-to-white diameter was calculated with digital calipers and anterior chamber depth and keratometry from the IOL master, and was collected preoperatively, and the volt was calculated postoperatively. So the type of phakic lenses to be implanted was decided by the patient, which most probably might have been influenced by the cost, in that ICL is costlier than IPCL. And patients who had a manifest cylinder more than 0.5 diopter had toric phakic lens implantation. Others had a spherical phakic lenses. And the customization of the phakic lenses was done by the company based on the data provided. The statistical analysis was done using the SPSS20 version, and Wilcoxon sign rank test and Mann-Whitney U test was used to compare the statistical significance. So our study included 65 patients with 40 in the ICL and 25 in the IPSL group, and that is 116 eyes of the 69 in ICL and 47 in IPCL group. The mean age was 26 in both the groups, and the mean spherical equivalent was -8 in ICL and -11 in IPCL. And toric phakic lenses was implanted in 64 ICL patients and 42 IPCL patients. The mean follow-up for ICL was 22, and the IPCL patients had a higher follow-up of 35 months. So the uncorrected visual acuity in both the groups showed statistically significant improvement from a preoperative vision of 1.28 to a postoperative logMAR of 0.23. And this graph, we can see that 85.4% of the ICL and 78.8% in the IPCL had maintained their preoperative BCVA or had a gain of lines when compared to the preoperative BCVA in the postoperative UCVA. And the percentage of eyes achieving emmetropia was 55% in the ICL and 60% in the IPCL. And those with a spherical equivalent less than 0.5 diopter was 72% in the ICL and 88% in the IPCL, and there was no statistical significance between them. The volt was seen to decrease from 1 month to the last follow-up period in both the groups. And specular count was also found to decrease with a regression rate of 7.5 in ICL and 7.1 in the IPCL. Coming to the complications, one patient in the ICL had to undergo lens exchange due to low volt, and one patient in the IPCL had rotational instability, and one in the ICL had residual error, both of which didn't go for resurgeries. Cataract was there in 2 of the ICL and 3 of the IPCL patients, and one patient of IPCL had pupillary block glaucoma, and transient IOP rise due to steroids were seen in 6 of the ICL and 4 of the IPCL patients. The safety index, which is the ratio of the mean preoperative BCVA to the postoperative BCVA, was 1.09 in the ICL and 1.12 in the IPCL. And the efficacy index, which is a ratio of the mean postoperative UCVA to the preoperative BCVA, was 0.86 in the ICL and 0.89 in the IPCL groups. So the improvement seen in the BCVA and UCVA was consistent with that of the published literature. And the gain of the lines in the postoperative uncorrected visual acuity when compared to the preoperative best corrected visual acuity might be due to the fact that this phakic lenses causes the image formation which is closer to the nodal point. And it was seen that 85.4, it was such a gain of line was reported by Sachdev et al. In their study also. There was loss of more than 2 lines in 5 of the patients, of which 4 was due to progression of myopia and 1 was due to the rotation of the lens. And those which and the spherical percentage with residual spherical equivalent less than 0.5 diopter That was also comparable to the previous studies as done by Sachdev et al. In their 1-year follow-up. And about the incidence of cataract, postoperatively after 1 year, there was PSC was observed in 2 patients of ICL and 2 patients of IPCL group. And 1 patient in IPCL had a late onset visually insignificant faint anterior subcapsular haze. So in those two, where it was visually significant, phakic IOL explantation with the phacoemulsification and cataract IOL implantation was done. And about the resurgeries, 1 patient due to low volt had underwent resurgeries, and 1 patient post IPCL and ICL had a residual error which did not go for resurgeries. The transient IOP rise in IPCL was due to an inadequate pupillary peripheral iridectomy, which was in the older version of the IPCL, which was corrected by enlarging the iridectomy. And the transient IOP rise seen was usually it subsided with the withdrawal of the steroids. And the safety indexes and the efficacy indices in our study are comparable to those studies that has been reported previously. And previous studies has also reported that the volt is seen progressively decreasing over the follow-up, which is also similar in our study. And the endothelial cell regression is most happening in the first 1 year and has been reported to be between 5.5 to 8.5%. And in our study, it is coming to 7.5 and 7.1 in ICL and IPCL group. And the merits of the study, our study is that it is only 1 previous study has been there in the literature, which is comparing the ICL and IPCL, and that was for 1 year. So our study has a comparatively higher follow-up. The limitation of the study is its retrospective nature. And to conclude, there is no statistically significant difference in the outcomes between IPCL and ICL, and both exhibit comparable safety and efficacy in treating myopia. And having said that, IPCL may be a better option in patients who who want a better refractive correction and financial constraints may not affect them. Thank you. These are my references.
Both your study and the other lady's study are from the same center.
Yes, sir. Yes, sir.
So much of variation in both the studies.
Hers was 3 months follow-up, and I included minimum 1 month follow-up, 1 year follow-up.
Okay. Because the incidence of glaucoma and all is totally
Yes.
different.
Patients must have overlapped, no? And that was
ICL1 because her study is
yes, sir. Yes, ma'am. Actually, because these
No,
patients who had minimum, since I included minimum 1 year follow-up, some of the patients who actually had complications in the initial period who didn't turn up for follow-up in the later had been missed in the study. So that might be the reason. Some few cases have been missed because they didn't come for the total 1 year follow-up.
how do you say resolve the fact that IPCL patients have better follow-up than ICL patients? In your group, IPCL have better follow-up than ICL
Actually,
patients.
that is just an incidental happening. I just
What do you
follow-
think could be the reasons?
I can't think of any. Sir.
how the patient chose the lens, is it?
Yes, ma'am.
Actually, the initial lenses which came up in IPCL had many.
That didn't.
Yours is showing little less.
That is why, ma'am, we had complications in the first 3 months because this 1 year I wanted a minimum 1 year follow-up. Many of the cases had to be excluded.
But you should tell the
You should have
denominator.
if you
Include
had
the denominator. You should tell us what are the total number of procedures done during that study
Okay.
period. Yeah.
Yes.
Can you go back to the first? You tell us what is the denominator, then you can tell what is the numerator you have studied.
Oh.
So you can have worst case scenario and the best case scenario. In that situation, you have to see. So number of patients 65, number of eyes 116. So, but how many were done during that study period?
Yes.
What was the denominator? Do you remember? Because she had a higher denominator.
Huh.
But the study period is different. Your study is different. When was hers? I think it was 2000. Yeah.
This is from January 2015.
Yeah. Study period.
No, what I think is, I don't know, I'm just thinking now. we are looking at something different, comparative of two designs or two techniques, I think we should include the early post-op
Okay,
also.
yes, ma'am.
Torics, both were smart torics, or the ICL required rotation.
I didn't understand your question, sir.
Torics that come with IPCL are smart torics.
Ah,
Just
yes, sir.
place them at
Yeah,
0
IPCL
or
is
ICL you had,
ICL had to be rotated.
and the rotation issue
Yeah,
you
yes,
had
but
in which one?
IPCL.
Uh,
We had with IPCL.
yeah,
Because ideally
one
you should not
IPCL will have
with
rotation.
The corneal diameter and all those measurements.
White to white was measured using digital
same
calipers.
person does it or different?
Sir, one person only. The
Single
operating surgeon only measured it.
So sometimes if the surgeon is busy, the assistant will measure,
No.
there could be a disparity probably. That is why I'm asking. That disparity is there.
Yes, ma'am.
So it's caliper based.
Digital caliper based.
reading.
Yes, sir. Okay. Thank you, sir.